Okay, here we go, the last section of the week 3 lecture. Okay, so as we get into all this anatomy, we're getting a ton of it in the cadaver class and some of it, a lot of it in this class as well. I want to keep applying it to the real world. I want to keep applying it to what you're going to be doing in practice. So really you want to be kind of thinking about, at this point in your education, where am I using this stuff in my everyday life? Because that'll eventually translate to your patients. So, as I'm going through my day, grabbing my keys, I'm taking a drink of coffee, on the computer, which muscles, which joints am I using? Keep applying it to yourself. Keep thinking about those kinds of things. And just along those lines, let's apply it to Francis. Again, make that connection. And kind of how this would work if you were a therapist, kind of breaking Francis down, trying to think about his muscles weakness and what we can do about it and how it affects his ability to do the things that are important to him. Where was Francis weak? He was kind of, and as we go through these really should start to be popping into your head, because these are the kind of questions you may get on the exam, connecting the anatomy to the function, especially in this class. Where was Francis weak? He was kind of weak all over. Didn't get into a lot of the story, but his balance was affected by his core weakness, weakness around his quads and his hip muscles. Definitely weak in his shoulders, which is what the OT was focusing on. How does the therapist know that he's weak? He can make an educated guess, but how does he really know what was causing his weakness, and how can he kind of quantify his muscle weakness? In terms of his arms, his elbows, and his hands, he could do manual muscle testing. I don't know if it was in the story or not. I can't remember. I don't think it was. But he did do manual muscle testing to figure out, he's got very weak shoulders. Other parts of his body are very weak. Makes him very vulnerable. What else would tell you that you think Francis is weak? You know certain things about him that are automatically going to tell you, he's going to be weak. This guy, most than likely, he's going to have issues around weakness, issues around certain muscles. They're going to be impacting his safety, his ability to do what he wants to be able to do. Why do you know this? Number one, he's older gentleman. Number two, he's in pain. We know pain causes weakness. Number three, he has not been very active. He was in a hospital bed for a length of time. He's been ill with the different issues that put him in the hospital. So he's kind of telling you before you even walk in there, this guy's probably going to have some weakness issues. How did this weakness cause limitations in ability to perform certain parts of ADL? ADL are activities of daily living. IADL are instrumental activities of daily living, more complex activities of daily living. Activities of daily living are kind of what it says they are: brushing your teeth, getting dressed, making the bed, making breakfast. All these activities you have to do to function in your daily life. OT spent a lot of time on these particular categories. So how was it impacting his ADL's IADL? Well, we know he had been falling. He was struggling to get out of that chair, off the toilet, in and out of bed. He had a high bed, I believe. Making meals, getting the mail, making furniture, fixing furniture. All these things were impacted by his weakness. So the OT goes in, sees, has a good idea, he's going to be weak, confirms he's weak with his testing, and then, okay, what he wants to be able to do, he wants to be safe, stay at home, do those essential things at home, those essential ADLs, IADLs he needs to do. Wants to fix up furniture. You need to get certain key muscles strong for him. How do you address this in his treatment plan? He went after the pain with the ultrasound. He went after the pain with some trigger point massage. You'll learn how to do that. Some basic stuff. He did exercises with his shoulder. He started in a gravity-reduced plane because it's easier to move your shoulder on his side in bed, on his back in bed. And then he got stronger. Then he was ready for resistance. And then he found out he wanted to fix up furniture, perfect resistance, kind of higher level activity. Let's progress to that and get you healthier, doing the things you want to be able to do. So let's think about this idea of fixing furniture. And if you look at that photograph closely, you can check that out. I don't think Francis could get down on his knees. If he did, I'm not sure he could get back up. But assuming this guy is in this position, can we think of some prime muscles in his shoulder and his elbow that he's going to use? He's using a lot of different combinations of muscles. But there's some key ones that I would think, and you're going to get this with experience, that he needs to do this task. Along with the joint range of motion, needs certain muscles to be strong and to be working efficiently, adequately, functionally. Let's watch, just envision him doing this. His elbow's coming down. It looks like it's flexed around 90 degrees, roughly. So the elbow is flexed 90 degrees. Looks like it's a little bit forward. So I would say it's flexed a little bit, kind of fixed in place. And as he does this brushing motion, coming in, coming out, he's going to move his hand towards his stomach medially and then laterally. To me, that's internal rotation, external rotation. Key muscle, key area anatomy, anatomically. If I had to pick two muscles that I thought would be key to work on with this guy, in terms of his emotional strength, I would say his internal rotators. The big internal rotator, as we just learned, is the subscapularis. One of the big external rotators is the infraspinatus. So those two shoulder muscles I would choose for this activity. Painting his furniture, I would say, or even staining it, I think is one of the lecture questions. I would say the subscapularis and the infraspinatus. And versus just memorizing this, try to figure out why does that make sense to you. It needs to make sense to you. If it doesn't, ask me in the lab, email me, I can help you walk through it to a degree. What else, elbow-wise, is he using? I would say his elbow flexors, say the biceps, brachialis probably is helping a little bit, flexing his elbow. You could argue that his deltoid is kicking into, probably. It's not clean cut, it's gray, but when you get these questions like an exam, I'm going to make it obvious. So we're talking muscles here versus, off on his hip or his back or something. So you're in the right ballpark. What you say has to make sense to me. Okay. Then going back to our lecture questions. All right, so the first question, 5 causes of muscle weakness. Can you think of that off the top of your head for that quiz? Thinking of Francis, the pain, the age, disuse for him are 3 big ones. Other ones, pain, disuse, age, neurological conditions, trauma. Remember, somebody fractures a bone, the muscles get instantly weak. 3 reasons to measure muscle strength. Shows the patient progress. To me, that's number 1. It really gets their buy-in. They can see, oh, this is actually working. I'm getting better. Number 2, it shows you as the therapist that you're on the right direction. This is telling me that what I'm doing is being effective. And number 3, it shows the insurance that you're making a difference. They're getting better. You can show in an objective way, an accepted objective way, that they've gotten stronger. Give one example each of how we assess muscle strength through client observation, client expression, client physical reaction. Client observation, a good word to use here is compensate. When they try to lift their shoulder up, they compensate. They don't have that pure movement plane, they're compensating. Client expression, they're grimacing, showing pain in their face. Client physical reaction, they're blanching, turning white, short of breath, that sort of thing, heart racing. 5 contraindications of manual muscle testing. 5 contraindications of manual muscle testing. Excessive pain, fractured, you don't want to be pushing on the fracture, generally speaking. A lot of these are generally speaking, there are all exceptions. Spasticity, the tone of the muscles off, they're too confused. Cardiac, you don't want to be stressing their heart if there are cardiac issues. What is an example of joint rolling and shoulder joint kinematics? Keeping this simple, think of the humeral head rolling within a glenoid fossa. fossa. So example of joint rolling and shoulder joint kinematics, the humeral head rolling within a glenoid fossa. What are 2' shoulder muscles involved in sanding furniture? We'll stick with the internal and external rotators. Internal, subscapularis; external, infraspinatus, one of the bigger ones. You could argue the deltoid too. Anterior, posterior deltoid, even the middle deltoid involved as well. Okay, and then lastly, this also shows you what's coming up for that quiz that you want to be ready for. Monday's 9:14 lab. It's going to be the lecture questions, so we just want just one of those lecture questions. Obviously, you're not going to know which ones, so you need to know them all. And then the anatomy that's posted on Canvas. And if you're having issues figuring out the lecture questions or whatever, pop in the virtual Zoom meeting on Sundays, 10 to 11. Email me, and we can do a Zoom if you can't make it that time and you have questions. And then before the lab, please watch the videos. Keep watching them over and over and over again. They are your go-to thing for getting ready for that practicum. Okay, so I'll see you guys later.